special meeting with Human Resources with our Alliant benefits. It's July 1st, 2024. The time is 11 a.m. I'm calling this meeting to order. In attendance are Commissioners Matari, Brooks, and Duncan, with Commissioner Brooks joining us by phone. Are there any changes to the agenda? Okay, hearing none. Public comment. Hearing none. Our one item is the Alliant benefits, our presentation for the FY25 health insurance options. So, Scott, are you going to lead us out?
Sure. Scott Burkhart with Alliant. Okay, let's go ahead and dive in here. I think everyone's aware we're experiencing a higher cost period than we've experienced in the past historically, and correspondingly a higher projected budget increase than we've seen in the last few years. Before I turn it over to David to go into the details of that, wanted to give a little history perspective. This chart here is the per employee per month claims costs on the medical plan on a rolling 12 average every couple months, so dating back to 2018 since we first took over Alliant. And as you can see, there's cycles up and down. The red line is actually the Kaiser Family Foundation trend line. That would be the market norm of increases on a medical plan over that time period. The blue lines are the county's costs. So you can see that Kootenai County's average increase over that time period has been 3.5%. The market trend has been 7.5%. So historically, Kootenai County benefit plan has run extremely well over that time period. Correspondingly, and that represents, let me go back real quick, that represents the medical plan. The medical plan is about 93% of the Kootenai County benefits budget. So as the medical plan goes, so goes the budget. On a self-funded basis, which the county plan is, you're going to have monthly swings in claims up and down. Over a 12-month period, we can pretty consistently project that. But then over time, you're also going to see cycles and trends and periods of higher costs and periods longer term of lower costs. David's going to talk about some unique factors specific to Kootenai County's higher costs this year, but also relative to the market that actually are unique from what we haven't seen in the past following COVID. As I mentioned, the medical plan costs pretty much drive the budget. In 2018, we had a 1% increase overall for the county budget. And then we did have a couple years of higher, 10% and 11%. But the last 4 years, we've experienced some much lower than trend increases. So also, just to set the stage a little bit, just as reminders, we haven't had any increases in employee contributions over the last 5 years, and no changes to the core employee benefits over the past 5 years. Recent program enhancements, the Edison Healthcare Centers of Excellence. We've had just got our first report on this, and this is extremely positive results. There's $337,000 net savings from incorporating that program. And what that is, again, it's second surgical opinions and, if appropriate, treatment at some of the best healthcare in the world, the Centers of Excellence that are contracted through Edison. And what that includes is 18 member outreaches, so 18 members contacted Edison, with 6 who actually followed through. 5 of those 6 procedures were recommended not to have surgery in the second opinion. One of those did proceed with a surgery, and it resulted in significant savings. So the change in pathways along with the actual surgery add up to those $337,000 net savings. And also the PMR Primary Care Clinic. We've been talking about that for 2 or 3 years, and here we are. Opening day is upon us, I believe, in the next week or two. So with that, I'm going to turn it over to David, and this is a duplicate slide, but David's got some different perspective on it.
Right. Well, I would tell you that the slide would look pretty similar for just about anybody. If we look at our book of business, it's going to look very similar to the slide. And the thing to keep in mind is COVID, right? So when was COVID? If I look at 2020, because those are rolling 12, We can see how it dipped down because people weren't going in for care for various reasons. Some people didn't want to. Some stuff wasn't open, and then even when stuff was available, there were backups, so I couldn't get in right away, and so it took some time. We also lost a lot of physicians, and so you see in 2021, 2022, we started to see a little bit of that comeback, and then we had another dip. And so there's been a lot of noise, and that's what we call it in the data when we really can't see what the ongoing pattern is. Usually it's not as severe as this, but like I said, we're going to see this for just about everyone. If you want to go ahead and click on the next one. So that in mind, when you're trying to project the budget and see how you're performing, that causes a lot of variability. For the current 8 months, right now, the projection was, about $8,285,000. We're about $8.7 million, so about a $400,000 deficit, which is the first time we've been at least in a deficit position in the last several years through 8 months. Usually we finish worse than we begin, but I would tell you, like I said, 2023 was probably the worst year I've seen on our book of business since I've been doing this in a while. Pharmacy trend last year was high 17%, which is double what it usually is. And the big driver of that was GLP-1s. Those are the weight loss medications that you see for diabetes, Ozempic, Mounjaro, those things. And that had some impact for you as well. The bigger impacts for you in the last year have been an increase in immunosuppressive medications like Humira, Stelara, and that's been growing for you for about 4 years. Humira lost patent protection in the last year. Stelara is losing patent protection next year, so there is some help on the horizon for those. We had an increase in MS medication, which is expensive, and then also in medication for cancer, so oral chemotherapy. That's usually going to go away on its own because that's not a long-lasting treatment. And so those are the things that have driven it, and including the fact that we also had more babies born in the most recent year than we had in the prior years. And so that also drives some increased costs. So that's been driving, where we are right now. If we look forward to the future and what that looks like as a projection, we're looking at about a 9%, if you look at the top line, total cost, a 9% increase from what's projected for this year to what we are kind of suggesting that you should project for the coming year. The caveat with that is, we're coming off of a peak, and unfortunately, we don't know if you consider that chart. Is that going to be the new level post-COVID, or are we coming down off of a hill? In which case, the 9% might end up being a little high. But it's, again, difficult to tell at this point, and it's going to be different for each group on what that performance looks like. Then you also have the impact of the clinic. We're taking that into account, but that could have a greater impact as well, or a lesser impact, really depending on how much usage we get immediately. But from what I understand, there's already a huge line of people wanting appointments, and so that's going to make a difference and should have a positive impact much quicker than you usually see. The net cost that you see, 10.6%, what that means is if you don't change how much the employees pay for the medical plan, dental plan, then you actually absorb more of that. And so that's at 10.6%. So that's just important to keep in mind. The cost of not passing on any contributions is 1.6% more. If you were to pass on the exact same contribution, so their cost increased by 9%, then your cost would increase by 9% as well. And then we're projecting that the employee counts stay about the same as what the projection was last year. Some of those haven't even quite hit that number yet because the growth wasn't quite what we were expecting at the time that we set that last year. If there's a change in the future, either fewer employees or greater employees, then that also has an impact. But again, for this projection, we're not assuming a change in the projected number of employees.
Good.
Any questions on that?
I've got some. Can you go back to that chart? The first
Yeah.
one with Kaiser? Can you kind of explain what is on the left column there, what those dollar amounts represent, and the blue bars? Because normally I look at lines that are related to that, they kind of give you an average on the bars. Here you have what appear to be mutually exclusive data sets. Is that correct?
They're not mutually exclusive, so I will give you a full breakdown on this chart. So on the left is the per employee per month spend of the medical plan. And every blue bar is a rolling 12 months. So December 18 is January through December of 2018, the per employee per month. And we look at that because
That's Kootenai employees.
that's Kootenai, yes.
Okay.
So, and we look at that because the reason we look at a rolling 12 is there's less fluctuation. If you look at the monthly patterns, they're all over the place and you can't really see what's going on. So we follow the rolling 12. And the starting point, we looked at the average Kootenai increase and what that is over time. If we had a line for the blue, that would be a 3.52. And that would kind of go through from the beginning to kind of the top of the last bar. The average KFF increase, that's Kaiser Family Foundation. So they do a health plan survey every year. And they look at plans across the country. And we look at their average increase in that same time frame. It's 7.54% increase. And that is including changes in benefits. So if people make a reduction in their benefits, they're just looking at the rate increase. So the benefits have reduced in that time frame as well, but we're not taking that into account. We're just saying, on average, if your cost increased the same way that the Kaiser Family Foundation survey and the rest of the universe basically increased, you would be sitting at where that red line is, not where you are. And the good news is, like I said, there haven't been plan design changes. You haven't done things to mitigate that. You've just been more steady in the cost. Now, some of that is the benefit of being in the inland Northwest for a while. In the inland Northwest, we've not had the same experience as a lot of people in the rest of the country. That may be changing as hospital contracts change and get negotiated, and the fact that we're dealing with some of the pharmaceutical challenges that everyone else is. But for a while, we've not had the same kind of increases here that people experience in the Southeast, for example, or the Midwest, California. And so that's one of the reasons we're below. We've had pretty steady enrollment. You haven't gotten as much older as some other groups get year by year, depending on, who you're hiring. And so there are other things that have some mitigating factors that reduce that, but we have done better.
So these are employee expenses or county expenses, employer expenses?
It's the claims expense, so just the claims expense over that time frame.
Okay.
And it is the expense for employees, spouses, and children, but we group it all as a per employee per year expense because you budget per employee per year.
So if the total county claims, let's say, were $10 million in a given year, and we had 700 employees on average each month, that's just 10 million divided by 12 divided by 7, just so we've got a consistent way to express that on a per employee. But it includes dependents and their spouses and kids, and it doesn't factor out any employee contributions received. It's only the claims cost, just for a point of relativity.
And does the medical industry, is that driving a lot of this? Especially since COVID, I mean, finding staff is difficult. A lot of things have gone up.
Yeah, I could have a very long conversation with you about that. There's a lot of different things that are driving it. Staffing is a big one. I mean, a lot of doctors retired. A lot of doctors have moved to the teledoc because they can do that from different locations and set their own hours. A lot of doctors have moved to urgent care settings. Those are all reasons why the on-site clinics have become more and more important, is to address that shortage. Hospitals have largely indicated that they're losing money post-COVID for a lot of different reasons, but part of that is traveling nurses and their staffing needs that have changed and made it more difficult in order for them to staff properly. And then when they have the shortages, they have to pay more for the people that they have. Other than that, the pharmacy has been a huge driver of trend for a while. And even though those medications have lost patent protection, usually when a whole class of drugs, because you have Humira and Stelara, are starting to lose patent protection, you usually see an uptick in that beforehand. And we've seen that. And it's not just that the price point goes a little higher. You've actually had more people using those medications. And I've seen that across the board, which is why some people have looked to say, hey, how do we reduce that pharmacy spend? And then the GLP-1s, those are the weight loss medications. Our book of business trend was about 18% on pharmacy. It was 9% if we didn't count the GLP-1s. And so that whole new class of medications is going to be the biggest challenge for everyone moving forward. because those are going to continue to grow. You only cover those currently for diabetes, but they might have expanded uses in the future. And so we're using, when we did our calculations for the future, we used a higher trend this year than we've used in the past, in part because of hospital contracts coming due and because of the impact of GLP-1s and how those are going to impact everyone.
And then just on the couple of screens later, you have the total dollars. That one there.
Yes.
So you're expecting the county's expense for FY25 to be 13 million for the health plan, if you will.
As a whole.
Health, dental, vision.
Yeah, as a whole.
Yep.
So we're going up just a little over $1 million. Contributions are the next three rows underneath that, and then the net cost to the county. And those are the number of people who are who've signed up for the plans.
That's the projection
The
of the number
projection.
of people.
If more people sign up, then that number up top, the 13.5 million, will actually increase.
Correct.
So this is-
It's not really people signing up per se, because that's pretty steady as far
It's
as
the
number.
claims.
It's how many more people you hire. Like, so if you grow and move to 800 employees, that cost is going to go up. If for some reason you were to shrink, then it would go down. But it would be dependent on who you hire or who goes away.
So that leads to a little bit of a balancing act between our vacant positions and whether or not we hire this year and fill those positions. Okay,
Yes.
thank you,
Oh, you're welcome.
thank you.
Bill, any questions?
No, I really don't. I think it's pretty straightforward. Unfortunately, it's all numbers driven, and it's clear what's happening.
Okay, thank you.
You ready? Okay, so as far as strategy, what do we want to do in 24, 25 to focus on with the benefit plan, given a 9% budget increase? And continued emphasis on the PMR near-site clinic. We think that's the best decision we could have made last year and going forward, is implementing that clinic. It's gonna help us mitigate costs, greatly increase provider access, assist with mental health access. Also, continued emphasis on the Edison Centers of Excellence availability. There is no downside to individuals calling Edison just for second opinions or exploratory. And the more people we use that, there is exponential return on investment. Continued emphasis on the mental health and the resources that we currently have available on the benefit plan, such as the EAP and other resources.
Can you explain how that would actually save us money?
The emphasis on mental health resources?
Yes.
Yeah. David, do you want to take first stab at that one?
Well, I think the biggest thing, the biggest issue with mental health, and specifically depression, in that area, is that people that are suffering from depression are not adherent to what they should be doing with other conditions. So the cost for someone with depression, severe depression, isn't just in the depression itself, because that treatment is not really as expensive. The medications aren't very expensive. You have the regular consulting, seeing the physician. But the issue is, if I'm depressed and I have diabetes, or if I'm depressed and I have hypertension, I am more likely to consistently be on my medications that I need to be on. I am less likely to do the things that I need to do to make sure that I'm healthy. And then those turn other claims into much larger claims later. And so that's why you want to continue that focus. And post-COVID, across the board, mental health claims have gone up dramatically for all kinds of different reasons, as we've all experienced. And so you have a lot of new people that are showing up, whether they never went in the first place or whether they're new instances or they're feeling that anxiety and depression. And so having that emphasis there is to help make sure that if they can keep that in control, they keep their other conditions in control, which is the biggest thing we're trying to avoid.
And how do organizations typically address that? I mean, what do they tell people, go out and get an evaluation, or how do you implement something like this?
Right. So there's this is continued emphasis. So this is not saying anything extreme. It's like the emphasis is more in the communication during open enrollment and when someone's hired to make sure that people understand the value of the programs that you currently have in place, like the EAP. So, you know, EAP is one of those most underused benefits that people have, and you can call them for a whole host of issues, from mental health to considering separation and divorce, you know, a full range of gamuts that you have someone you can talk to. And those are usually a fairly helpful first step. And then they can then help you indicate whether or not you need to move forward for actual help, you know, with depression. And so the emphasis is focusing on there. The next step on those is to say, hey, we are not meeting the need of our people. And if we're not meeting the need of our people, how do we do that? And then you look at kind of a teledoc situation where you have physicians on call that they can reach out to, or I had another one in my head that just went away.
So if
Maybe I need it.
If an employee speaks with a therapist, it's private and confidential and protected information.
Absolutely.
Oh, yeah.
Absolutely.
I mean, that is some of the most private information that
Okay.
you're actually going to get on the medical side.
Okay, thank you.
And one of the things, you know, one of the biggest things is just continuing with the messaging and the communications that it's okay to talk about it, right? And getting people more and more comfortable in talking about it. And then utilizing the resources that we currently have available. We've got an EAP plan available. We've also got MD Live Behavioral Health, which is expanded, you know, through virtual. The problem is most people at times of crisis don't know about them. And unless we're repetitively communicating the awareness of it, people don't call them and utilize them. One of the biggest things I see with the PMR clinic is even though we don't have a psychologist or clinical psychologist on staff, that in-person doctor and nurse is going to be one of the most important things that we do for our employees. Just having someone to talk to. And most people don't even know how to take that first step. Who do I call in a mental health crisis? Whether it's crisis or just ongoing depression, or who do I even call? Well, just going to the PMR clinic, they can take that burden on and help lower the temperature and make a plan. And it's just saying, here's some resources that you can take that next step. That's going to be one of the biggest advantages I see of that clinic. So, but let's keep talking about it, keep communicating it, and that's what we're referring to here. Aggressive RX negotiations. We've already done this. We went back to Regents, asked for deeper discounts. Excuse me. Asked for deeper discounts on the RX plan. They initially came back, I think, at a $70,000 discount. We got that up to $300,000, and that in large part is the difference between the initial 12% budget down to 9%. So we've got that in writing, additional discounts from Regents. At the end of the year, as we get closer to the stop loss renews January 1st, and we'll market that as we do every year. We'll be aggressive of that. If we, you know, the current stop loss is with CBRM. It's different company from Regents, but related in ways. It's seamless coverage. Even if we have to change stop loss carriers or if there's advantage to us, there's no member disruption for that. That's more of a behind the scenes thing. So we will do that. Another big topic is consider adding short-term disability. It's a $220,000 annual cost. Relative to the fiscal year, it'd be $165,000. And I believe that this was included in your budget numbers, right?
Yes.
The 220,000 add. So that is included in the 9%, assuming that was added. And then obviously we're considering employee and dependent contribution adjustments. We're not making any recommendation one way or the other on that, other than to say, you know, during COVID, most employers didn't touch employee contributions for a year or two. But we are 3 or 4 years past, and employers in the market are now readdressing that. And so if there was a desire on the county's part to help mitigate that 9% cost by adjusting employee contributions up to that level, that'd be well within market norms to do so.
will be mitigated in 10.5 to a 9.
Yeah. Good point. So.
And then higher contributions would take it lower, but that, at a certain point, when do you get on the market? And so those are the discussions we typically have. The difficulty in doing the budget is always the budget is October through September, but the plan rates are January. And so those changes happen a little bit later, and typically we're pretty early for setting the rates at this time for then. And so that, those discussions are important though, because they do impact 9 months of your budget.
So on the short-term disability, if we were including it in our FY '24 or '25 budget, it would be 220?
It'd be, for the 24-25 budget, the coverage would start January 1st, and so you'd have 9 months of that 220, which would be 165,000.
Oh, gotcha. Okay. And we couldn't start it early this year?
You could, but
We could, but we thought just align it with our regular benefits would probably be
Sure.
the easiest manner to do it.
Okay.
How does the short-term disability help us as far as keeping our costs down, from a strategic perspective?
do you want me to take that, Sylvia, or do you?
So the auditor's office and HR met. We have our vacation donation program that is dying a slow death. We don't have the accruals to offset the need of employees for paid leave. So our strategy was to look at what other entities are doing, and this is a benefit that they're offering. Will it reduce our claims and overall medical expenses? Probably not. Right.
One of the benefits, though, is that when an employee is out, they're only receiving 60% of their pay. So there's a higher incentive as a manager that my employee is going to come back to work because they want to get their full paycheck again. Whereas on vacation donation, they're just, it's not quite that way. So I think there are some advantages from a management and an accounting perspective, like administration of the program. That's kind of why HR and auditor brought it forward this year. For some of those reasons.
And then it's more consistent. All employees would get the same type of benefit, where with our vacation donation, it's direct donations typically, and the more popular you are, whatever, the bigger group you work with, the more hours you get donated. And then if there's anything left, it goes into the general pool, and it's not covering, it's not sustainable.
And then just one last question. Sorry I have so many here, but can you explain to me how marketing the stop loss will actually help with saving a little bit?
Sure. So the stop loss coverage right now represents maybe 5% of the total plan cost.
It's pretty close, yeah.
Yeah, so it's about 5% of the total plan cost. And in any given year, the average inflationary increase on stop loss because of leverage trend, which we won't go into, is about a 20% increase. That's what we expect to see, 15 to 20% increase on that every year. We've also got favorable stop loss provisions through proprietary contracts with Alliant. We've got those with 10 to 12 different carriers. CBRM is one of those. Those main provisions include a refunding provision, which allows us, if we have a positive claims experience year, to get up to, I believe, 15% of the premium refunded to us, and we have taken advantage of that. There's also a rate cap of 50%. And I know that sounds like a lot, but if we get an ongoing $2 million claim, then they're capped at a 50% max increase. That's a great protection to have. Those are the primary provisions. Now, each year we're going to look at those provisions, we're going to look at the market. If we can get much better provisions elsewhere in terms of premium rates, refunding, rate cap, what else am I missing?
You got most of
Those
it.
are-
You got the important ones.
Those are the main ones. If we can get much better provisions on those, we'll bring that to your attention and say, here's an advantage. But realistically, on a premium basis, direct premium, we might only be able to impact 1 or 2% of your total costs. But on the back end, through refunds, through rate caps, et cetera, it might be a much bigger number.
And it's actually 11%.
It's 11 on the stop loss,
Stop loss is
11% of the
11%
medical
budget.
plan, but yeah.
Okay, so it has nothing to do with marketing to the employees?
No,
No.
it's invisible.
No, it's marketing to the vendors who sell stop loss.
Yeah.
And it's that if someone has a very large claim, you're not on the hook for all of it. And so that's earlier when Scott said it's seamless and behind the scenes, it's nothing that the employees are even involved on or know exist. And generally it doesn't interact with them directly.
Yeah, and we're in a great position with Regents. They've been fair in their renewals. It is seamless coordination of the claims. There's no clunkiness of having to, front money for a claim and get reimbursed from a stop loss carrier. So we're in a good position. It's just if there is a much better position we can be in, we'll bring that to your attention towards the end of the year. And that's just we had that come up a couple years ago where we strongly considered moving it, and but Regents ended up coming back, or CBRM ended up coming back and matching the provisions, and so we held tight.
Okay. All right, well, thank you.
You don't have anything else, is that? Yeah. I think that's the end of what we have to present, so.
Okay. And then Brandy, were you prepared to go through some of the scenarios that you had sent to us?
If you want to. I wasn't sure if you wanted to discuss those today or at tomorrow's budget meeting. That's up to you guys.
Okay. Any thoughts on that? Bruce?
I think that at the very least, we probably have to have a serious conversation about the employees contributing a little bit more. But as far as the specifics of that, it kind of fits into the bigger picture, and I'm happy to have that discussion tomorrow.
Okay.
Okay, talk about it tomorrow.
Yep.
Okay.
Bill, any other questions?
No, I think that's good. I know Scott does a great job trying to protect us, but there's just so much he can do. And I would like to have this discussion tomorrow.
Okay. Anything else related to this? No? All right. Public comment? All right. Hearing none. 11:32, meeting adjourned. Thank you so much.
Thank you.